Hello, everyone, and happy Wednesday. Thank you for joining us today. My name is Ryan Googe, and I am the Executive Director of the Partnership to Advance Cardiovascular Health, known as PATCH for short. Today, we're going to have a discussion on clinical practice guidelines. Why do we have them? How are they developed and used? And how can we streamline and speed up the process by which guidelines are adopted in the clinic so that we can support patient-centered care for the growing number of people living with cardiovascular disease, diabetes, and other comorbidities. Today's program is a follow-on from a report jointly released by PATCH and the Diabetes Policy Collaborative on the intersection between cardiovascular disease and diabetes. In this report, the Diabetes Policy Collaborative and PATCH outline the intersection between these two disease states and discuss patient-centered care and informed treatment decisions. You can find the link for the report below the live stream. Before I go further, I want to thank our speakers for making themselves available to us today, as I know they are extremely busy people. I also want to extend a special thank you to Alyssa Presley at the American Heart Association and Sarah Bradley at the American Diabetes Association for helping me secure our AHA and ADA speakers. I need to mention that membership to PATCH is free. And as long as you are a stakeholder organization interested in public policy that affects patients with heart disease, we would be honored to have your perspective included in our coalition. You'll see below the live stream a Q&A box. We encourage you to ask questions as they come to mind. We'll have some designated Q&A time at the end of the interviews, but if you submit a really good question during our conversation, I will ask it. We have 4 panelists today. On our first panel is Thomas Getchius. Tom is the Director of Guideline Operations and Strategy at the American Heart Association and the American College of Cardiology. He has held roles in guideline development and implementation at the American Academy of Neurology and at the Heart Rhythm Society. Joining Tom will be Mindy Saraco. Mindy is the Managing Director of Scientific and Medical Affairs at the American Diabetes Association. She guides the Professional Practice Committee in their development of the standards of medical care in diabetes each year. She also works with expert writing groups to publish consensus reports and scientific reviews on various topics related to the management of diabetes for a professional audience. For our second panel, we're joined by Dr. Michael Honigberg. Dr. Honigberg is a cardiologist at Massachusetts General Hospital and an instructor of medicine at Harvard Medical School. His fellow panelist will be Dr. Kaavya Paruchuri. Dr. Paruchuri is an advanced clinical and research fellow in the Cardiovascular Disease Prevention Center within the Division of Cardiology at Massachusetts General Hospital. She has worked closely with the MGH Center for Innovation in Digital Health and with industry collaborators on several digital health endeavors, including implementing smartphone-based applications, wearable monitor utilization in patient care, and disease management platform development. But to get us started, I want to give PATCH's board president, Dr. Dharmesh Patel, an opportunity to open this discussion. Dr. Patel at this point is a fixture in our programming, and I think we're slowly building him up as America's favorite cardiologist. Dr. Patel practices medicine in Mississippi and is a stalwart advocate for heart patients around the country. Dr. Patel, the floor is yours.
Ryan, thank you. That's a hard act to follow, but welcome everyone to this important program. I'm certainly glad to be here. My name is Dharmesh Patel, and I'm a cardiologist practicing in South Haven, Mississippi, and in Memphis, Tennessee. Over the course of the last year, we have witnessed a reinvigorated conversation around cardiometabolic diseases. Principally, that's because the thing that has dominated our headlines, the coronavirus, has exacted a heavy toll on patients with diabetes or cardiovascular disease. Consider the COVID mortality for those with an existing cardiovascular condition is a staggering 40%. A recent study was published that showed that 20% of people diagnosed with diabetes who contracted COVID died within 28 days. As alarming as these facts are, it is important to remember that even before the coronavirus brought attention to all things healthcare, cardiovascular disease and diabetes had devastating impacts on Americans and the American healthcare system. For instance, cardiovascular disease kills more Americans every single year than coronavirus has killed this year. Every year, more than 800,000 Americans have a heart attack, and about 1.5 million are newly diagnosed with diabetes. If someone does have diabetes, they are 2 to 4 times more likely of dying from a heart ailment. And within the last few years, after decades of improvement in cardiovascular health, we saw progress begin to fade. In fact, deaths from heart disease stopped declining and started increasing. I'm very sad to say this is the first time in history that the older generation may outlive the younger generation. Cardiovascular disease patients today cannot be pigeonholed as just cardiovascular disease patients. Comorbidities are on the rise in America, and cardiovascular disease patients have an assortment of medical issues. I see it every day in my practice. I just saw 6 before I came on. We are treating a patient's cardiovascular disease, diabetes, kidney disease, AFib, heart failure, etc. Rarely anymore can patients be placed in silos of care. To be frank, I think they should be in continuum of care. It is important to point out that renewed interest in the intersections of diseases, in particular cardiovascular disease and diabetes, was catalyzed in part by a 2008 directive made by the Food and Drug Administration, which required that new diabetes medicines must undergo cardiovascular safety trials. Well, what resulted was a number of medications were found to not only not threaten patients' cardiovascular health, but actually benefit patients' cardiovascular health. Since that time, clinicians have been flooded with pharmacological agents that treat multiple diseases concurrently. It's a great problem to have, but with all the innovations that come, challenges exist too. And that is why we're here. Today's topic comes in, interestingly, medications do not exist in silos. And that means medications that treat these diseases touch many medical societies, cross disciplines, and complicate our traditional understanding of disease-centered care. Clinical practice guidelines are created by medical societies to recommend best-in-class treatment and are care-based on the best available evidence-based medicine. But do they keep up with innovation? And when are they truly updated? Why does it take so long for them to translate into common practice in the clinic? Why is it in my case that studies that have been shown lag up to 6 months to a year for me to actually be able to give the patient that medicine? And thereafter, other challenges exist. Patch's mission is to seek policies and practices that accelerate innovation, improve cardiovascular health for all Americans. Accelerating guidelines, writing, and clinical uptake, I believe, is a less commonly cited but nevertheless key aspect of meeting our goals for cardiovascular and diabetes management. I really look forward to our panelists today, and I wish you all a wonderful meeting. And thank you, Ryan. Over back to you.
Thanks, Dr. Patel, for those insightful words as we get started here. So Tom, Mindy, thanks for being here. Really appreciate it. To get us started, when I was looking at the literature on scientific innovation and implementation lag, there's a general consensus that goes back, frankly, decades, that we don't do a good job of getting new therapies to the clinic fast enough. You often see lots of dates or years kind of cited for how long it takes for this to happen, but I've seen it frequently stated that it takes 17 years for research evidence to reach clinical practice. Now, in that journey from evidence to clinical uptake, a major step along that path is a medical society updating its clinical practice guidelines. So in this first panel, what I'm hoping to do is level set on the guidelines writing process and its importance. So my first question to both of you is this. I'm a physician. I go to school for 20 years or more. I've been practicing for 20 years. I know my patients. I know what medications are on the market. Why do I even need guidelines? Tom?
Yeah, thanks, Ryan. So as I prepared for this conversation, and I'm very pleased to be here today, I recalled a statistic that I heard at a guideline conference a few years ago that said medical knowledge doubles every 7 to 8 years. But as I looked in the literature, again, in prep for this, I found a citation that said medical knowledge was projected in 2020 to double every 73 days, which just seems astronomical. And for me, I'm not a clinician, I'm not a physician, And it feels like it's hard enough for me to keep up with my administrative work and responsibilities at the American Heart Association, at the AHA and the ACC. And I do professional training and continuing education. So as a physician, I couldn't really imagine practicing without guidelines. So our guidelines provide the readers or practitioners with current summaries of the evidence on particular diseases or conditions. And in the case of our guidelines at AHA and ACC, they're written for that practicing cardiovascular clinician, and they move the provider to treating the patient from the way that they were trained to actually following the evidence and the recommendations developed by our expert committees. So guidelines are meant to supplement the clinical encounter and used in concert in discussion with the patient. So thinking of like a three-legged stool, think of one leg as that clinical judgment and those unique patient characteristics, and then the guidelines supplementing that encounter, and finally the patient's preferences and values. So when you think about guidelines, they don't dictate care or provide a standard of care, but they support each individual encounter. And that's why we need these guidelines.
So Mindy, why do I need guidelines?
Right. So similarly, the American Diabetes Association guidelines really do provide a distillation of the latest evidence. Our professional practice committee will review the evidence. They'll grade the evidence so that when the provider is seeing the recommendation, they can get a sense of the type of evidence that recommendation is based on. And we try to create our guidelines in a way that sort of makes the evidence actionable. So, and our constituents are the endocrinologists, but they're more often than not the primary care physicians. So who are, dealing with not just diabetes and cardiovascular disease, but a full gamut of comorbidities and diseases and sort of concerns of a patient. So helping to distill the evidence into recommendations that can be used, directly in patient care with the patient, is what we're aiming for.
So Mindy, when I think of guidelines writing, I'm imagining some very academic looking folks probably wearing some heavy tweed jackets, behind closed doors, considering the evidence, making big decisions, and then updating these guidelines and these recommendations. But can you kind of, unpack that for us a little bit? What does the guideline writing process actually look like at ADA, for instance?
Sure. Yeah. I mean, it's not a secret group of people. We have a professional practice committee. It's a national committee. And it's about 16 members each year when our standards of medical care of diabetes comes out, and that's what we call our clinical guidelines. Their names are printed in the book, so you can see who is on the committee. Their conflict of interest disclosures are also printed in the standards of care each year, so you can see sort of what their conflicts may or may not be. That's something that we take pretty seriously, and we want to be transparent there. And who are they? They are really experts in a variety of areas. They're pediatric endocrinologists. They're primary care providers. They have expertise in older adult care. They have expertise in management of diabetes and pregnancy, pharmacologic expertise. We have pharmacists on the group. We have diabetes care and education specialists for, so that we recognize that education piece is really important. They have expertise in epidemiology, public health, really the full gamut of the topics covered in our clinical guidelines. So again, we ask for disclosures of conflict of interest, and like I said, those are printed in our standards of care. And we aim for diversity both in background, experience, practice setting, and we look for do we have expertise in all of the areas that we need to really publish the full, complete guidelines for the year?
And how often are the guidelines updated at ADA, Mindy?
So our guidelines are updated annually. So each December, our guideline is published online. It's actually the January supplement to Diabetes Care, one of our premier medical journals. So we are updating it really throughout the year so that we can publish in December, and then we sort of start back up in January. And so that's our schedule. And our standards of care include all of our practice guidelines. So they're all sort of like lumped together in one.
Got it. So Tom, can you talk to us a little bit about how, the process may be similar or different at AHA and ACC?
Yeah, very similar to Mindy with respect to that composition of the writing committee. So yes, we do also collect those relationships with industry. We vet those and determine if the relationships that the writing committee members have are relevant to the topic, or if they should just be a comprehensive relationship. Yes, we disclose it, but it would not conflict or be a relevant relationship where someone couldn't vote on those recommendations or on those sections. And again, with that composition of the writing committee, very similar to ADA, AHA and ACC want to involve other professional medical organizations to either partner on the guideline or collaborate, so that we can involve that discipline and that professional medical society at the outset of the project in hopes that we can obtain their endorsement. And that endorsement can signal to the readership of the guidelines that, X discipline, maybe it's anesthesiology, maybe it's electrophysiology, it could be pulmonology, it could be podiatry when we're thinking about peripheral arterial diseases. So that endorsement that's published in the guideline on the title page really signals to the readership that that discipline and that society was involved, they've endorsed, and they support the recommendations and the development process of this guideline. I'll say that AHA and ACC is taking a page from ADA in this effort to improve the development process and shorten that development timeframe. So we are striving to really publish our guidelines over a 14-month period from the time that we initiate a project. When we think about having a kickoff, a meeting of that writing committee. And again, pre-COVID, we would have those as in-person kickoff meetings for a day. We'd kind of level set the process. We'd talk about the project. We would make sure that we are very inclusive in terms of our scope. And then after that, we would conduct the evidence review, deliberating on that evidence. We would have a consensus conference once all of that evidence has been compiled into a single manuscript, go through our reviews, our approvals, and our publications. And I think when we think about updating AHA and ACC guidelines, our process has been over the past number of years to wait until enough evidence accumulates in this area to either do maybe a focused update, maybe a few sections or chapters of a guideline, let's say on atrial fibrillation or valvular heart disease, or if there's been kind of this paucity or this dearth of data that's published over a period of time, we'll actually commission an entirely new document and update what we have done in the past. And you can see that on the AHA and the ACC websites separately, that we published a guideline on valvular heart disease in 2020. That was an update of the full guideline that was published in 2014. A couple focused updates we commissioned in 2017. And we said, now for this valve guideline, we're going to take all of that data from probably 2013 to present and publish that in a single document.
So Tom, so we have the guidelines updated. So I would imagine that, a major uptake or a major factor in the uptake of a new therapy that's been updated in the guidelines, say, is whether someone wants to pay for it or they're incentivizing the use of it. So my question is, how do payers or health plans factor into guidelines? Do you think that payers use the latest medical society guidelines to guide their coverage decisions?
Well, what I can say is that in terms of my work with the AHA and the ACC, we are focused on the development of those guidelines, and then AHA and ACC independently and separately from me and my team take care of the dissemination, the promotion, and the implementation of those guidelines through the development of performance measures or performance metrics, and then even the implementation of those guidelines through data registries, or like the AHA registry, the Get with the Guidelines registries. So I know within AHA, there are initiatives to promote some health equity and ensuring access to affordable and quality care. And AHA does advocate for coverage decisions based on guidelines and policy statements. And we do want coverage to align with the guideline recommendations. But as I had said earlier, the guidelines aren't the standard of care. So they do support that clinical encounter along with the shared decision-making in those engagements with the patient.
Got it. So Mindy, the other day, I saw a study, someone actually posted it to LinkedIn. They were very excited about it. It was on SGLT2 inhibitors, which are medications that treat type 2 diabetes, but they also have a lot of other benefits for patients. And a doctor commented on the post and said, is there anything that SGLT2s can't do? And what I think that illustrates is that we increasingly have these medications coming to market that have dual or more benefit. So my question is, can you give us an example where a medication has a cardiovascular benefit and a benefit for people with diabetes? And so both sets of guidelines need to be updated. And do the societies work together when that happens? And what do you do if the timelines don't meet up? Like, how do we work out that tension?
Sure. This is something that, we working on all the time. So right, the evidence from the CVOT trials, like Dr. Patel had mentioned earlier, I mean, it's evolving and new findings are published all the time. And, there's, of course, the cardiovascular connection with diabetes, and we see a lot of renal. There's a lot of evidence coming out on the renal indications as well. So we work very closely with the ACC. The ACC actually, they have designated representatives on our cardiovascular section in our standards of care guidelines. And in the past 3 years, we've received endorsement from the ACC on that section. So they're involved in the development of the guideline. The ACC then reviews it internally and then ultimately endorses at the end, so that when we do publish, we have that ACC endorsement. The idea is to hopefully clarify things. We don't want providers to have two conflicting sets of guidelines from two different organizations, because that won't help. It won't help them decide what's the best treatment. And we also hope to sort of hope that it improves our dissemination. So the ACC constituents will hear the same message that the ADA constituents will. And of course, there's overlap, but we feel as much as possible to collaborate with other organizations. It's really going to help clarify the message and relay that message. We work closely with AHA with our No Diabetes by Heart initiative. The same thing, we work with that group to sort of help get the guidelines into providers' hands, so that when they're working with patients on treatment options, they have the latest evidence-based medicine available to them. And we work also with ACC on having representatives on their decision pathway guidelines, and then ultimately endorsing their guidelines, again, sort of to increase the reach and unify the message. And I guess in terms of timing, sure, right, we all have different publication schedules, but having these close relationships with the staff really helps in that. So we've been working with our ACC and AHA colleagues for a while now, and sort of we make it work as we understand that we have a unified mission there. Great.
Tom, next question to you, and we've kind of touched on this a little bit, but really, my question is, how do we keep up with innovation? I mean, we have so many therapies now coming to market, and I think that our next panel will talk about this a little bit. But not only that, and you mentioned this earlier, we almost have like this data overload happening. There's so many studies coming out and so much data that's being produced now from, top flight universities and labs. So how do you keep the guidelines current with all the latest and greatest that's coming out?
Yeah, it's a great question, and something that we continue to struggle with. And again, with my time at the American Academy of Neurology and my time at the Heart Rhythm Society, that question of how can we speed up the development of guidelines? How can we analyze this trial or these late-breaking clinical trials and incorporate that into the guidelines and push that out to the practitioners and the readers sooner than oh, let's just amass some data, put out a new document, publish it, and hope that somebody reads it. So AHA and ACC are looking to take a page from ADA's book with those living standards. And we at AHA and ACC are building upon our infrastructure and putting a laudable goal in place to scan the literature every 6 months to monitor for changes on specific guideline topics where we've published. And as you said earlier, Ryan, there are a lot of top-notch universities and a lot of research that's being published. And in the cardiovascular community, we have 3 major meetings. We have the American Heart Association meeting, which typically takes place in the fall. We have the American College of Cardiology meeting, which typically takes place in the spring. So ACC's meeting is coming up in May. And then we have the European Society of Cardiology, and their meeting is taking place in August and September. So we have that May, we have August, we have November, where there's this late breaking clinical trial and new evidence that's being presented and published. So we want to move from let's wait until a couple years have gone by to publish a focused update or a brand new topic and get that out sooner. So we're currently in the works. We, the AHA and ACC, are currently in the works with our governance committees to finalize some of these draft criterion. But here's kind of where our current thinking lies. So if there's new data that would either upgrade or downgrade a recommendation, that would trigger an update. If there are device recalls, if there are FDA black box warnings or safety concerns, that's an automatic look to see if we need to kind of rescind those recommendations, maybe put something out to say, look, new evidence has come to light and we no longer stand behind these recs. And then there might be new data that's published that we didn't actually address in the previous iteration of the guideline. We'd also process that and maybe put some sort of amendment or some sort of additional sections into the guideline. And we actually hope that happens more often than not, because each of our guidelines have a future research recommendation. So when we have this writing committee and this group of experts that have gone through the evidence base and the literature to develop the guidelines for these various indications, you have these top-notch individuals that say, well, if we actually had trials designed this way, or if we put something together in this manner, or if these researchers would have presented their results or changed their study criterion like this, we could actually generate higher quality data, which would improve our evidence base, which would give us guideline recommendations. So as we think about operationalizing and implementing the criterion that I just talked about, we want to keep our writing committees intact for a number of years post-publication, having them keep their relationships with industry unchanged. And then we'd formally survey that literature every 6 months. And if nothing changed in 6 months and the guideline still stands, we're thinking we may inform our readership of that decision. But once we hit one of those thresholds, or once we need to pull one of those levers that I previously talked about, we would enact that writing committee, process that literature, review that literature through our peer review process, and then go through approvals. And again, maybe taking that page from ADA is maybe posting something on the website, and then at a specific period in time, republishing that document, so you can always come back to this one source that is the most current and the latest and greatest guideline on X condition.
Before I move to Mindy, Tom, let me ask a question that actually was submitted by the audience.
Yeah.
And you mentioned keeping that guideline writing committee intact over time. What are the actual requirements for being put on that committee in the first place?
Sure. So it depends on kind of which position you're looking at. So if we want to have somebody serve in a chair role, we want someone with that seniority and that gravitas that has maybe held a leadership position within AHA or ACC. We want somebody that is an expert in the literature. And if you are a chair, you need to be free of relevant relationships with industry, not only during the writing committee effort, but 1 year pre formation of that guideline all the way through. And then ideally, if you want to stay on and keep intact, you'd have your RWI unchanged. And then for the writing committee, positions, we're certainly looking at the competencies. So what is the scope of that guideline? Do we need anesthesiology? Do we need electrophysiology? Do we need pulmonology? What are those types of competencies? And then we are looking at diversity and inclusion, geographic location, maybe where you have practiced. And we're certainly looking at those competencies, and then finally looking at the relationships with industry. More than half of our writing committee needs to be free of relevant relationships. And this is no shade on individuals that are involved with device companies or pharmaceutical companies. There are certainly roles there where our experts can inform that type of research and that type of data generation. But so that we can have our readers of our guideline continue to trust the recommendations that we put out, more than half of our writing committee has to be free of those relevant relationships. That's a great
Very
question
good.
that was submitted.
Yeah. Mindy, just a final question for this panel before we go to our next group. And we kind of touched on this a little bit, but can you talk a little bit about how the societies have changed or are changing the process of writing, of keeping these guidelines current as the scientific world moves more rapidly? And, it sounds like the standards of care have something to do with that, but can you talk a little bit about how that process has gone at ADA and how you all envision the future as well?
Sure, right. And Tom mentioned our living standards of care process. So in 2018, we realized that, the evidence is just moving so quickly. And even with an annual publication of the guideline, that in between time, our big annual clinical meeting is in June each year. So that was a big time when there were late breaking findings being published, and with the other annual meetings of other societies as well. And then just research, coming out, or FDA changing an indication for a drug. So there were changes throughout the year that we felt were important for providers to know about and to help them understand how to act on those changes. So in 2018, we published our first living standard, and there, Tom talked a little bit about the threshold. So our 3 triggers include if there's an approval of a new treatment, medication or device with potential impact for patient care, publication of new findings that support either a change to the recommendation or a change to the evidence level of the recommendation. Or sometimes ADA will publish a consensus report that may update the recommendations in the current version of the standards of care. And in that case, we would publish an update. And when these either new findings or new approval of treatment or medication or device would affect the recommendations in the cardiovascular disease section, which is often the case with the CVOT trial findings and the new indications that will come out mid-year, we involve our ACC colleagues so that they can review the new language that we're proposing for the living standard update and approve that. And then we'll publish and update the sections. And all of that happens online on the Diabetes Care Journal website. That's where our updates are posted. And we'll also, communicate that to our constituents so that they're aware that a change has been made and they could check that out. So that they know, the latest in terms of clinical guideline.
Perfect. Great. Thank you, Mindy. Well, thanks both of you for, unraveling what sometimes can seem like a difficult process to understand. We really appreciate it. If you'll stick around, we're going to bring Tom and Mindy back at the end after we talk to Drs. Paruchuri and Honigberg. So to round out this discussion, I'm going to bring up our next 2 panelists to the screen. Drs. Kaavya Paruchuri and Dr. Michael Honigberg to get the clinician perspective and on guidelines. Before we get started there, though, I want to say that one of the benefits of having an incredibly intelligent wife is that she has incredibly intelligent friends, and that's how I know Dr. Paruchuri. And so when I was working on this webinar, I called her to discuss some of the topics and eventually said, you should just do this webinar with me. And she said, sure, I'll do it, but Mike has to do it with me. And so I called up Mike and said, hey, Mike, can you do this webinar? And Mike said, I'll do it, but Kaavya has to do it too. So glad you guys are looking out for each other. It's good. Thanks for being here. I really appreciate it. So to get us started, kind of like I shot to Tom and Mindy, I've got a hot seat kind of question for you guys. So, and Kaavya, we'll start with you. how well do you keep up with the guidelines?
Sure. So I think that I have a little bit of an advantage here. I'm pretty fresh out of fellowship, and where I trained, a lot of the people have contributed to the making of many of these guidelines. So I've been exposed to them repeatedly over the course of my fellowship. And since I'm staying on at an academic institution like MGH, it just really reinforces the importance of keeping up to date. So I'm encouraged to participate in lots of discussions, attend conferences, and it's a very organic way for me to keep up with them. In terms of things that I do to stay current on my own, I do subscribe to as many journals as possible, but sometimes it feels like I'm drinking from a fire hose, and I'm only able to read maybe the table of contents or one or two articles that catch my eye. Another way that I found that really helps keep me current is social media and Twitter in particular, where there's a number of doctors and cardiologists who help break down large amounts of information to quick 280 character pearls that I can take back to my clinic. I especially like that with Twitter, it's easy to read on the go, so I can catch up while waiting for an elevator rather than having to sit down and dedicate time to a whole article. Twitter, or cardio Twitter as it calls itself, has really gotten very sophisticated in medical education, even in the few years that I've been using it. And these days, many of the tutorials offer CME credits in addition to just knowledge and discussion with many of the colleagues across the nation.
Dr. Honigberg, how about you? How well do you keep up with the guidelines, and how do you keep up with the guidelines?
Yeah, thanks. I share a lot of Kaavya's, Dr. Paruchuri's thoughts and sentiments. I guess I would add two things. One is that I'm a preventive cardiologist who conducts research in the preventive cardiology space. And so, I look to the guidelines to inspire my research questions, to make sure that I'm asking questions that are relevant to the current evidence and the current guidelines, and also ask questions that are sometimes inspired by the guidelines. Sometimes guidelines are actually, I would say often the guidelines are behind the evidence, but occasionally they're ahead of the evidence in some respects. And that creates an opportunity for us to ask research questions to maybe fill in some of those gaps. I would also say, Kaavya and I both come from the perspective of working at an academic teaching hospital where we're in the position of training junior folks. I direct our preventive cardiology rotation for our general cardiology fellows. And so being in a teaching role really sort of keeps you in the hot seat. It forces you to be up to date so that you're teaching your junior colleagues the most up-to-date evidence. And so it's actually, I find that it forces me to stay current. I guess the last thing I would say, and I suspect we'll come back to some aspects of this later in the session, but it's honestly quite important to understand the guidelines for your interactions with payers. I say that it's kind of unfortunate that we spend so much of our time fighting or communicating with the insurance companies, but often it takes, actually citing the guidelines in order to get certain, particularly newer therapies approved for our patients, where we know that the evidence robustly demonstrates benefit, but these are patented, often expensive medications where we have to sort of justify the use in a particular patient. And so I sort of have my like pre-made letters and the excerpts of the guidelines with the relevant sections highlighted, because I find that helps me get through some of these prior authorization discussions more quickly.
It sounds like you both passed that section, and Tom and Mindy will be happy to hear that you're very current on the guidelines. It's great. So, but I want to actually, you touched on this a little bit. You're at a teaching institution, and I think that is unique in that you have, for me, when I'm thinking about this problem, I think it stands to reason to me that you have somewhat of a generational disparity potentially, right? So you have, at a place like MGH or Harvard, you have these pioneers of medicine that are kind of in the twilight of their career, and they've done things a certain way their entire career. And then you've got, as you guys mentioned, young minds coming right out of medical school or right out of residency, and kind of turning in and out of the clinic. So, but my question really is there a generational disparity between, keeping up with guidelines and guideline implementation, or do you think that there's that certain groups of people are paying more close attention to the guidelines than others? Kaavya?
I do think there's somewhat of a generational component to things. So there are some things that are just commonplace to me that were cutting edge to very senior physicians when they were training. One example I can give is beta blockers. The randomized trials proving their mortality benefit in heart failure were from the 1990s. So by the time I was in training, it was a standard of care, but folks in practice for 30 plus years have had to adjust to that, plus many other things that have come up as medical knowledge has accelerated since then. And I can imagine it can be hard to keep up unless you're making a dedicated effort towards this. Similar to what Mike has said, I've had a lot of colleagues mention they love working with medical trainees for this reason. It's a way to stay in touch. It keeps them in the hot seat, and a lot of the debates that you have about patient care and the art of medicine really go back to the guidelines and the evidence that support various suggestions that are in there. Other ways I've heard my colleagues tell me about keeping up include social media, which is actually how I got onto Twitter. They also focus on medical podcasts that can be played during morning commutes, and of course, journals and journal clubs. The common thread in these things seem to be that they're all ways to distill down primary literature or to focus on small amounts of it, since it can be daunting to sit down and read an entire guideline document. Conferences used to also be a great source of information pre-COVID, and they still exist virtually, but it's just not really the same. So I think people are reaching towards more, novel virtual options these days.
Mike, what would you add there?
I guess I don't have a ton to add. I do think there probably is some generational component. It's sort of not applicable to everyone, but I do think there is an element of you establish practice patterns pretty early in your training, and those stick, and change is hard. And as folks get more senior in their careers, they get busier. And I think you sort of fall back on what you know. And I think the activation energy to start incorporating novel therapies, probably goes up. The older you get, the farther along you get, the more competing responsibilities you have with the things you do day to day outside of patient care, administration, research, and teaching. So I do, and I think it's a hard challenge, particularly as the number of potential therapies we can offer patients increases, and as the population gets older and the average complexity and comorbidity burden of our patients goes up and up and up, the number of potential risk-reducing therapies we can offer gets larger and more complex. And I think if you've been in practice a long time, your sort of willingness to sort of dive into that and get mired in that and spend a lot of time on that when you feel like what you know and what you've worked with for a long time is good enough, that willingness is probably lesser than somebody at Kaavya's in my stage.
So I read a quote the other day. It said that it's estimated that between 30 and 40% of patients receive treatment that is not based on scientific evidence. Now, the folks who wrote that were referencing all medical disciplines, but my question to you both is, and Dr. Honigberg, we can start with you. What do you think the state of play is for cardiovascular medicine? Do you think we do a good job treating the guidelines in CV medicine?
I think the data is pretty robust that we do a poor job of treating to guidelines in cardiovascular medicine. I think there is an element of overtreatment in all disciplines of medicine, and there's some overtreatment with respect to cardiovascular prevention in the primary care and cardiology settings. But I would say the much more common problem in both primary care and cardiology is undertreatment, failure to adequately address and mitigate risk factors in the sort of what we call the primary prevention setting, the setting before someone has developed overt clinical symptomatic cardiovascular disease, that we are insufficiently aggressive about treating to blood pressure targets and cholesterol targets, managing other risk factors like weight and exercise and diet and diabetes. And that's also true, perhaps to a slightly lesser extent, in the secondary prevention setting, which is to say in patients who have already had a cardiovascular disease event and have established cardiovascular disease. Again, I think some of this comes down to, we can talk about, there are many reasons why I think there are gaps between the current literature, currently available therapies, and optimal primary and secondary preventive therapies. Some of it is, again, sort of number and complexity of medications in an increasingly complex patient population. Some of it is sort of provider bandwidth to manage multiple new medications at once. A lot of it comes down to insurance and cost to patients, rising sort of co-payments and cost sharing that insurers are imposing on patients. And some of it is just at a certain point, polypharmacy, you actually do get diminishing returns and patients have side effects, and sort of perfect becomes the enemy of the good. And there are certain patients where throwing on the whole kitchen sink actually doesn't make sense in the setting of their global clinical picture. So it's a complicated question, but I think to sort of circle back to what I said at the beginning, we in cardiovascular medicine and in the cardiovascular aspects of primary care, we certainly undertreat more than we overtreat.
So, Dr. Paruchuri, Dr. Honigberg there talks a lot about the difficulties for a clinician. Can you touch on the patient a little bit? I mean, do you think we've talked this entire time about how there's so many of these new medications to market? I mean, do you think that there's a knowledge gap for patients, and do they understand that these options even exist?
I think there's definitely a knowledge gap for patients. Most patients understand when a medication is treating a clear symptom or a number. I have high blood pressure, so I take this pill and the blood pressure number gets better. Or I know I feel really terrible when my blood sugar number is high, so I take my diabetes medication to feel better. That makes sense. But the intangible links are a lot harder for patients to grasp. And even though we know diabetes is a major contributor to cardiovascular disease, and that poorly controlled diabetes accelerates heart disease and kidney disease, patients often think of them as different things. So they think this is my diabetes medication and this is my heart medication. And they often don't understand that just because one medication treats diabetes doesn't mean that there isn't a better medication out there that also treats diabetes and their heart condition. So I think that it's important for physicians to take the time to educate them as much as possible, but the gap is there, and I think that it's very difficult to surmount because there's a combination of misinformation as well as a lack of information, and finding a good balance between the two of them is something that most of us have yet to find a great way to deal with.
So a lot of work to do on the educational component for patients, it sounds like.
Mm-hmm.
Dr. Honigberg, back to you. I want to ask, in the reading of my literature on implementation science, there's an attempt to kind of break down situations in which guidelines are particularly valuable for clinicians. And those situations, as I've read, kind of are three. I'll outline the three. One is where scientific evidence is sparse. One is where there are multiple therapies that might be available. And the third is where there is uncertainty in terms of where the treatment options might be. What's the most relevant one of these for cardiovascular medicine, do you think?
Sure. I'll start with the one that it's definitely not, and that's number one, where the scientific evidence is sparse. We have no shortage of robust, high-quality scientific evidence in the field of cardiovascular medicine, and that is one of the reasons I love it. We certainly have no shortage of evidence. I think the answers are actually probably a combination of other things. I think number two, where there are multiple therapies available, is actually a big one. And it's increasingly true. I think of it in particular in the overlap space between cardiology and diabetes, relevant to the prior discussion, where we frequently encounter in our cardiovascular practice patients who have established cardiovascular disease as well as comorbid diabetes. And they may come in on a pre-existing regimen for their diabetes that doesn't include some of the novel cardioprotective agents that we're sort of increasingly adopting, and we know that are evidence-based, like the SGLT2 inhibitors and GLP-1 receptor agonists. And for many patients, their diabetes may be well controlled on a regimen that includes other medications. They may be candidates for both SGLT2 inhibitors and GLP-1 agonists. And I think as cardiologists, particularly when we're working I personally don't espouse the view that this isn't my problem. I think this is very much my problem, but I think many cardiologists look at that sort of complex landscape where they think, gee, I don't want to step on the toes of like primary care and endocrine. And I'm actually not sure. And I'm really overwhelmed and don't want to manage injection teaching in my cardiology practice. I think that's where there's sort of multiple available therapies it overwhelms already busy clinicians and they just say, I can't like take on this aspect of care. I think it relates to sort of uncertainty about what the optimal treatment option is for a particular patient. And I think it's actually probably an area where our cardiovascular guidelines could be more clear, particularly as they integrate some of the even more recent literature on, particularly the kidney benefits of the SGLT2 inhibitors and sort of guiding clinicians. If a patient's a candidate for multiple novel therapies, which one might actually be best tailored to that individual patient's comorbidities and needs? I'll stop there.
Okay. So Kaavya, as a kind of follow-up to that, can you talk a little bit about working across disciplines when you see a patient that, you're treating their cardiovascular disease, but you feel like, or you believe that their diabetes is not as well managed as it could be? Like, how does that work and how do you deal with that personally?
Yeah, it can certainly be a challenge. I think there is a lot of individual practice variation in how people handle the cross-discipline management, and it comes down often to individual patient situations. I actually had this come up in clinic recently where I have a patient who's followed the same kidney doctor for over 20 years, and he met me 2 years ago. So he was willing to hear about medications like the SGLT2 inhibitors from me, but it was only when his nephrologist brought it up that he was actually convinced to try them. So the messaging from the nephrologist happened because I reached out with an email to him being like, oh, this is a medication I think this person might really benefit from. I notice his A1C has been slowly creeping up over the past 2 years that I've known him. If you agree, maybe you want to talk to him about it as well. And so I think that it can be awkward to bring up when suboptimal care is present to a colleague, but we really owe it to our patients to address the situations. And when patient care is fragmented across institutions or state lines, sometimes the whole picture isn't always available to them. And in this case, he hadn't actually seen the most recent A1C because it was only within our system. So I think that it benefits both the practitioners and the patients for people to reach out and communicate about these.
Being proactive, definitely. So let's talk about implementation strategies. And Mike, I'll start with you. So, it seems from the research I've done, there are kind of two strategies at an institutional level to speed up the adoption of guidelines recommendations. You have workflow-focused strategies like clinical reminders, and then you have provider-focused strategies where you have physician champions who are facilitators of guideline adherence. Can you give us an example of something you've worked on or you've seen as successful in terms of guideline implementation and kind of speeding up that process in the clinic?
Sure. I actually think probably I'm going to give you a third that isn't one of the two that you just mentioned that
Sure.
I think is probably among the more effective sort of emerging strategies to improve sort of treatment to guidelines. And that's involving non-physicians in the process. And often these efforts are overseen by physicians and by clinicians. But I think at the end of the day, relying on a busy, stretched thin, and ultimately fallible single provider to make every individual prescribing decision, just realistically, the inertia is too slow. There's too much inertia. It's too hard to make meaningful changes in that sort of model of care. And so I think some of the most effective programs have incorporated non-MD clinicians to help with these efforts to monitor progress. I think about this in a couple of different scenarios. One is in the heart failure realm, where we know there are multiple very well evidence-based therapeutic classes that are really life-saving for patients with heart failure. But getting all these meds on board can be really hard, and particularly hard if a single MD is making all the decisions. And so at MGH, we're starting, and other institutions have as well, something called sort of guideline-directed medical therapy clinics for heart failure, where nurse practitioners, physician's assistants, and registered nurses are all either virtually or in person doing a lot of the day-to-day lifting of getting evidence-based medications on board for these patients. Another model is a model adopted in the Mass General Brigham system for the management of blood cholesterol and blood pressure, where pharmacists are using database review and in a purely virtual format, treating individuals with high cholesterol and high blood pressure to target. So I think those are really emerging sort of population health focused strategies that get around some of the limitations of the single clinician making all the decisions.
Dr. Paruchuri, you want to throw in an example?
Yeah, so I think Mike hit all the two big things I was going to mention. The telemedicine approach really takes advantage of the fact that it doesn't overburden physicians who are already extended as far as they can, especially with the COVID pandemic. This increases access to care and is able to show pretty surprising results. So in the Brigham example that he used, they actually had about a 20% improvement in cholesterol levels across all of the patients who enrolled. So that's a pretty dramatic change, and they increased prescriptions of statins within that group by another 25%. So 25% of those patients who previously were statin intolerant were actually found to have just not been trialed on a slow enough protocol or not been held through, and had their questions answered in a way that they felt comfortable continuing the statin. So I think that population level care is really the way to go with this. And as Mike was saying, we have various ways of targeting this, but I think that we have a ways to go.
So final question, we're running short on time, but it's an important one. And Mike, you touched on it a little bit at the top. Access is definitely a factor here. We can have all the therapies in the world, but if clinicians can be earnestly trying to implement, evidence-based medicine and implement guidelines, but if we can't get plans to cover these medications, you're going to have limited progress. So do you both think that do we have comprehensive coverage, or do you think coverage has gotten more difficult over time in cardiovascular medicine in particular?
Yeah, I'll quickly say, I think it's a combination of two things. One, it's, and this touches on the prior guideline discussion, is that when guidelines are behind the evidence, it becomes difficult to prescribe evidence-based therapies that aren't yet guideline endorsed. So there was like a solid 2-year period where I was really fighting with insurance companies to get icosapent ethyl, which goes by the brand name Vascepa, covered for my high-risk patients with atherosclerotic cardiovascular disease. And so prior authorization for therapies that haven't yet made their way into the guidelines is an ongoing challenge. I think another trend that I've really noticed a lot recently in the last year or two is an increasing move of payers to shift more and more co-payments to patients, even for covered medications. This has come up a lot in the lipid lowering space for things like PCSK9 inhibitors, as well as bempedoic acid, which is a really critical therapy for patients who have real statin intolerance. It also comes up in the cardio-diabetes overlap space with the GLP-1 agonists in particular. Had a little bit better luck recently with the SGLT2 inhibitors, but I think, when a patient is told your medication is covered, but it's going to cost you $500 a month, to my mind, that's not really coverage. Most of our patients absolutely can't afford that. And so it's a covered med, but we can't practically get it into the mouths or into the bloodstream of our patients. So that really limits us.
Absolutely. Thank you both for a fascinating discussion. If you'll stick tight for just a minute, we're going to bring everyone back up to the screen for just to finish things up here. And so we'll give the AV team just a second to pull everybody back up on the screen. There we go. So Tom, Mindy, welcome back. I actually want to just give you guys an opportunity to react to anything that you heard on this panel from the clinicians. Was there anything that popped out to you or you'd like to respond to? Tom, I'll start with you.
Yeah, Dr. Paruchuri, I heard you say that you use social media as one of the primary means to kind of keep up in the literature. And you also made a statement to kind of hit me right here, if you will, that, you don't have time to read the guidelines cover to cover. And yes, it's a labor of love. And yes, they are very long. So when you think about sitting down with the guidelines and wanting to, tease out information for your clinical practice, what would you really like to see in the guidelines? Maybe in the length or even in tables or figures that currently aren't there?
So I knew this was going to come back to bite me, but the way I currently interact with the guidelines actually is when I have a patient situation where maybe something is not completely clear, I'll pull them out and I'll use it as a teaching moment by the team of trainings with me And we'll go through why certain evidence might be in favor of one therapy versus another therapy. We'll debate back and forth, especially if it's not a conclusive push for one or the other, depending on what the various teams think. In terms of sitting down and reading them cover to cover, I think that they have a lot of information in them. It just can be a little challenging to find that chunk of time in your day, especially if you have a busy clinical practice. There's constant messages, constant noise in the background. So the synchronous versus asynchronous type of learning is really what my comment was getting at, where I can read in 2 seconds on an elevator versus have to like focus a little bit harder on the guidelines.
Right. Okay. Thanks.
Any last thoughts from our 4 panelists? Mindy, anything you want to share to wrap it up?
No, I thought that was really interesting also. And, I think about again, the primary care provider who is really, who is treating the full gamut of things, and sort of how the additional challenges that they have, because it's not just one sort of topic that they're trying to follow all the emerging literature on, but it's really the whole, it's just, I could see it being really overwhelming. And so thinking about, Tom and I work on sort of the development, but then really thinking about the dissemination and implementation sort of in a digestible, usable way is really, we are focusing a lot on that. And, things that you have said about, cardiology Twitter and podcasts, and then, the multidisciplinary teams you were talking about, like the non-MD, is sort of really thinking of creative ways to disseminate and ultimately implement, all of the clinical recommendations. So it's great to hear your perspective on that.
Great. Well, I just want to thank you for joining us today. It's been great. I've learned a ton. I hope that our audience has learned a ton. Thank you all for your insights, and be well. Thank you so much for being here today. But before I let everyone else go, I just want to mention that our next webinar is slated for May the 13th, just ahead of the American College of Cardiology scientific sessions. It's titled The Patient Pathway, Meeting the Needs of Patients Post-Cardiovascular Event. And we'll have a discussion with both patients and providers about the path that a patient takes after having his or her first cardiovascular event. So of the 800,000 Americans that Dr. Patel mentioned at the top who have a heart attack each year, nearly 40% have a recurrent heart attack. So why is that happening, and how can we meet the needs of patients better to prevent those second and third events? So that's what that will cover. You can register for that webinar by just clicking above on the events tab on our webpage. And we look forward to seeing you there. Thanks again for joining the webinar. Have a great week. Take care.